Hey, it's Hoyt again, and I'm going to be talking about psychiatric disorders in children and adolescents. So, a quick intro. So, psychiatric disorders in children can be incredibly hard for parents to identify. I mean, they're kids, and as kids, they're going to do crazy things. It's estimated that 1 in 6 children aged 2 to 8 years has a mental, behavioral, or developmental disorder. So only by understanding when and how to recognize these warning signs of a disorder in children can you then begin to help them. Today, we're going to explore some of the more common disorders and how you can recognize their signs and symptoms. The four topics we're going to be covering today are attention deficit slash hyperactivity disorder, oppositional defiant and conduct disorder, the autism spectrum disorder, bipolar, and mood dysregulation disorder. Um, these are some of the most common disorders that we see in children today. All of the other typical adult mental health disorders also apply to kids, but these are the ones we typically see. Um, some of the more common ones that also apply to adults are learning disabilities, eating disorders, and addictions. Those are seen in kids as well, just not one of the four topics, one of the most popular topics that we're going to be covering today. Um, Starting off with ADHD, attention deficit disorder. It's the most common childhood psychiatric disorder. According to the CDC, or Centers for Disease Control and Prevention, 10.2% of all children aged 5 to 17 were diagnosed with ADHD from 2012 to 2014. The picture on the right is the DSM-5 criteria for ADHD diagnosis. As you can see, symptoms of hyperactivity or inattention must be present before the age of 12. This is not something that's related to day-to-day events. It has to occur in multiple environments, at least two of them being home and school. It's got to interfere or decrease quality of academic productivity or social functioning, and it has to be present for at least 6 months. There are really two major types of ADHD, the impulsive and hyperactive type, and the inattentive and distractible type. Okay, there is a third type. The third type is the combination of the two, and it's the most common. But there's two symptom criterias, and you can see them also down below on the right. So inattention, it's characterized by a difficulty in paying attention, listening, and focusing. You can see some distinguishing factors right there. Hyperactivity, it's evidenced by fidgeting, the inability to sit still, running, climbing inappropriately, difficulty playing quietly, and talking excessively. Impulsivity, which is the third type, is evidenced by a difficulty waiting turns and constantly interrupting others, acting without consideration for consequences. That can manifest in both and is part of the third combination of the two. Attention deficit disorder affects 2 to 10% of school-age children. There's a triad of symptoms: impulsive, inattentive, and hyperactive. Those are the three that we just went over. Boys, oddly enough, are 2 to 3 times more likely to get the hyperactive or combined type, which are the most common types. So looking at some treatments, we're going to be looking at amphetamines, and they work to balance specific neurotransmitters in the brain that prohibit the child from maintaining attention and controlling impulses. They kind of work the opposite in kids with ADHD than they do the rest of us. Depending on whether the medication is short or long acting, it can help focus the brain and reduces common characteristics of ADHD for 8 to 9 hours, or with the short acting, 1 to 4 hours. So as you can see, it's a limited time frame. If the child's going to be attending school, you want to try to align the times of stimulation with their class schedule. You'll also want to let their teacher know. It's important that they know because they can do things like try to decrease stimulation, and it also gives a reason for why the child might be acting out. There's some common side effects of amphetamines are decreased appetite, stomach aches, and insomnia. So you want to watch out for those because this is likely going to be a long-term kind of a thing. Antidepressant medications may also be administered for children and adolescents with ADHD to help improve attention in addition to like decreasing aggression if they're really aggressive, or decreasing anxiety and or depression. So there's no prevention of ADHD, but with early recognition, peers can intervene and reduce the severity of symptoms, which is ideal. Make sure the family understands that this is a neurological condition and that it's hard for them to control, and they're not just blaming the child over and over. Is part of the behavioral training and parental support. Both of those are going to be key in getting a positive outcome. Some of these amphetamines I've listed here, psychostimulants, Adderall, you might recognize Adderall and Ritalin, probably the two most common. We have oppositional defiant conduct disorder next. We have diagnosis, evaluation, and treatment options here. As far as diagnosis, some of the common symptoms you will see is they often lose their temper, they're easily annoyed, they're often angry or resentful, argumentative, and defiant. You'll see them arguing with adults or refusing to comply with requests from various authority figures. They deliberately annoy others and blame their mistakes on them. They're being spiteful or vindictive at least twice within the last 6 months. So ODD is confirmed when 4 or more of the following symptoms that I just mentioned are present for over 6 months, including the being spiteful and vindictive twice within the last 6 months, according to the DSM-5. Oppositional defiant disorder is much more prevalent in males than in females. As far as evaluation, it's usually apparent before the age of 8, and also characterized by just seemingly random aggression towards animals, people, property. It's often coupled with a learning disability like ADHD or another mood disorder, so be on the lookout for that. It's also like for a cause, or looking for a cause is a good idea to do, because the child might have had multiple changes in caregivers that caused this, or a harsh or neglecting parent. They're much more likely to develop the disorder if that's the case, so you want to watch for that, or at least assess for it. Treatment, residential treatment if available or if it's needed, optimal school environment. You want to identify any underlying causes for the learning impairment, like I just said or just mentioned. And then the last thing, we have multi-systemic therapy. MST is an intensive home-based model of care that seeks to provide stability and improve the home environment, as well as strengthen and support their coping skills. Autism spectrum disorder. The DSM-5 criteria for this was recently updated in 2013 to include several individual developmental disorders under the same umbrella or netting. These disorders include autistic disorder and Asperger's. The current criteria is number one, it has to have persistent defects in social communication and interaction across multiple contexts. They have to have restricted and repetitive behaviors, interests, or activities. The symptoms must be present in early childhood, but may be delayed to a later age when society demands it, or it becomes more apparent just because they're more function later on, or more functional out in society later on. Symptoms that cause significant impairment, number four, in social and occupational or other areas of everyday functioning. Um, every 9 per 10,000 children are affected with autism spectrum disorder. Some associated myths. One of the greatest controversies in autism spectrum disorder is whether there's a link or not between childhood vaccines and the disorder. Despite extensive research, though, there is no study that is shown to show a link between autism spectrum disorder and any vaccines. In fact, the original study that sparked that debate years ago has been retracted due to poor design and questionable research methods. So some signs and symptoms. Signs are usually seen by the age of 2, before anyone has made a diagnosis. Each child with autism spectrum disorder is likely to have a unique pattern of behavior and level of severity. Imaginative play is generally done between the ages of 2 to 3. It is when a child uses their imagination to role play certain scenarios. Risk factors include being male. Again, boys are 4 times more likely to develop autism spectrum disorder. Family history, extremely preterm babies born before 26 weeks specifically, and parental age are all risk factors. So parental age, preterm babies before 26 weeks. For these children, the goal would be minimizing the disruptive effects of the autism on development. The part about imaginative play is they don't have it, or it's not evident by the ages of 2 and 3, which is, if you know anything about peds, it should start much earlier than that. So the signs and symptoms are noted on a spectrum. Some common signs and symptoms are fails to respond to his or her name, abnormal eye contact, delays in language development, fail that symbolic imaginative play that we talked about, doesn't express emotions, feelings, or appears unaware of others' feelings. So causes: autism is estimated to be 40 to 80% heritable. As far as treatment goes, occasionally atypical neuroleptics are used to decrease the stereotypical outbursts in behavior, but the focus is on enhancing adaptive skills with occasional therapeutic intervention. Disruptive mood dysregulation disorder is it's a condition where children or adolescents experience ongoing irritability, anger, or frequent intense temper outbursts. The symptoms of DMDD go beyond a bad mood. DMDD, or disruptive mood dysregulation disorder, account for youngsters who are extremely irritable and angry much throughout the day. Very similar to bipolar, the diagnosis only differs in when the symptoms occur. So again, very important to take note of that. I put down here persistent manic or hypomanic symptoms preclude the diagnosis. Mania or manic refers to an elevated or irritable mood that lasts at least 1 week. In hypomania, symptoms last at least 4 days. If a child has a severe temper with recurring physical or verbal outbursts, then ask your physician about the diagnosis of MDD. The diagnosis is specifically useful in children with an obvious mood disorder but don't meet the full criteria for having major depression or bipolar disorder. Treatment with this focuses on psychotherapy. If there are limited results, then amphetamine-based medications or SSRIs can be used if needed for supplemental control, obviously. Depression affects 5% of children and adolescents. According to the DSM-5, it has to have at least 5 of these symptoms listed here. This is not an intermittently affected by day-to-day activities. It's not intermittently affected, so it's not on a day-to-day basis. This has to be an ongoing thing. We'll likely see changes like poor concentration, lack of hygiene, distancing from other students, poor performance on day-to-day tasks, even including things like getting dressed and eating. Hypersensitive. They're going to be extremely hypersensitive to rejection, even on things that like don't seemingly matter to you. Depression might be apparent in their body language as well, or facial expression indicating depression or sadness. They might walk around all glum. All right, thanks for listening. Here's my sources.